let's dive into the madness. So all the learning that we had from our previous studies and our COVID VIT, we wanted to apply that learning to a larger scope and larger picture. So we went to a hunt on that, and what would be a larger picture or scope than lung cancer? If we look at few of the statistics, it is one of the largest contributor to the lungs-related, cancer-related death. 1 in every 16 American will be diagnosed with a lung cancer in their lifetime. And this happens to everyone. And within the time span of this talk, approximately 27 people will be diagnosed with lung cancer. So it's a very larger picture. As like any other diseases, early detection and diagnosis helps. Chest imaging protocols helps contributed really for the early detection, like chest radiographs or computer tomography. So which one would be better for the diagnosis? I think all of us know the answer right now, but back in 90s and 2000, it was not known. So there were so many imaging trial has been run. So we will be in our task, we'll be focusing one of this trial that called National Lung Screening Trial. It happened long back. They're trying to associate the early lung cancer detection to the likelihood of cure. So if we look at a few facts of this trial, it happened to a US-based population for over around 8 to 10 years. It included 53,000 patients, and out of that, they divided into chest and CT and chest X-ray imaging, and they're trying to compare what would be better, compare CT and chest X-ray diagnosis, and what is the outcome of this trial actually changed the landscape of lung cancer diagnosis in the imaging. They find out that you can reduce the mortality of lung cancer by 20% if you use CT compared to the chest X-rays. So if we see some challenges of the NLST, first of all, it was very expensive. It was $256 million to spend. And there are other few factors to run this trial is that there is a radiation risk because you are having a lot of population. The population diversity is questionable in many of the very large trials because they skew to a certain populations, and you also need follow-up requirements. But what is most concerning is the false positive rate. NLST is reported 24.3% false positive rate, and which is also contribute to the overdiagnosis. So how we can contribute from our point of view as a Center for Virtual Imaging Trial to tackle a few of these challenges? What if we want to do this trial in a virtual setup? Before I dive into that, let's look at how a clinical imaging trial looks like. To run a clinical trial, you need a screening population. These populations go to a screening center for the imaging, and finally, the imaging you have a expert reader, suppose radiologist read it and give you the diagnosis. Now, if you really want to replicate this clinical trial in a virtual setup, you need to replicate the screening population to a virtual population, physical scanner to a virtual scanner, and human readers with a virtual reader. So we have actually done all that part. So if I just show you the whole diagram of what the thing we are working over the past 1 year is called virtual lung screening trial. It's not been possible without the huge team effort that we had. So I just put pictures of few key personnel, but there are a lot of people who contributed to this project. I'm not going to run you through this whole mess, but I try to give you an overview of like 2 minutes how we did it. So every time, if we go to the overview of VLST, there are 3 key parts: virtual population, virtual scanners, and virtual readers. So when you have a person have a CT scan, we get that CT scan. We have an AI-based segmenter that we call DukeSeg. Loveson's developed it in our center. It can segment more than 140 different organs from our human body. And then it goes through a rigorous quality control, airway generation, texturization, and we finally got our voxelized model, which is called a virtual subject. Then in our center, we have the mechanism that we can simulate the nodules, lung nodules in our case. We can manipulate the different parameters of the nodule. What is the size you want? What is the you want the heterogeneous or homogeneous lesions? What would be the speculation? There are multiple parameters we can change to get like benign looking or malignant looking nodules. And then we insert that nodule to this virtual subject, and with this, we can have a virtual population with and without nodule. Once we have this virtual population, this population ran through some virtual scanners. So as we are trying to emulate the National Lung Screening Trial, NLST, we want to replicate the technology of that period. So we go through the studies, we find out that, so we are replicated two of the scanners that time used. We call them Duke Legacy W20 and W12, and one of the post-processing of the CXR. We run our virtual patients with this Duke Sim, which is a radiography simulator, and finally we get the simulated images. So we have completed our virtual population, we have our virtual scanner. Then the next part, where the AI contributed the virtual readers. So for the virtual reader part, what we did, we developed our virtual reader on clinical data set. We've gone through a public search. We find out that Luna 16 has a public data set for having lung nodule. So, and CXR, for CXR, we used Note 21, which is a publicly available CXR data set having lung nodule and the bounding boxes. We used this data set to develop identical detection model. Using this data set, we use the same model for in 2D and 3D, having the assumption that is somewhat of the same reader, but trained in two different modalities. We try to maintain the training strategy for both this model as close as possible. We can imagine a radiologist both trained with a CT and CXR. So they will be act like that. So once we have that model trained, we pass this virtual data to this model, and we get the bounding boxes for every nodule detected and the probability, what is the probability of that proposed candidate could be a nodule or no nodule. And then we can run a lesion level analysis or patient level analysis.